A 35-year-old shop assistant presented with fever, fatigue, weight loss, and myalgia for 1 month, and hemoptysis for 1 day. Sorry, 6 months.
6 months is fever, fatigue, and all.
Okay.
Hemoptysis is 1 day. So, how do you analyze and proceed with this problem? He is employed in Abu Dhabi as a shop assistant. 6 month fever, he has come home. After reaching here, he has developed hemoptysis also. That's his complaint. You want more details, it will be provided to you.
Sir, if you are looking at the differential diagnosis of fever,
Yes.
The non-infectious causes are malignancies and connective tissue disorders.
Okay. Malignancies, which malignancy you think present as fever?
Bronchogenic carcinoma.
Not the commonest presentation.
Lymphomas.
Bronchogenic carcinoma, commonly they come with cough.
Okay,
Well, lymphoma can present as fever. Yes. Any other malignancies you think can present as fever? Hepatocellular carcinoma, sarcoma.
Renal cell carcinoma.
That's right. Renal cell carcinoma, pancreatic carcinoma. So, pancreas, kidney, liver, retroperitoneal tumors, sarcomas can have, or any other tumor. Any other tumor can have fever. Commonly, these are things that comes to your mind. Okay. So, the second thing is connective tissue disease. Which connective tissue disease you are talking about when there is fever? Rheumatic fever? Rheumatoid arthritis?
Yes, sir.
Rheumatoid arthritis fever is not commonly seen unless there is associated complications. So, which one comes to your mind when you say fever? 6 months fever.
Systemic vasculitis.
Systemic vasculitis. Yes, broadly, yes. Primary
SLE.
vasculitis. SLE. Male patients with SLE are rare. Females are the candidates for SLE. Right. Any other possibility? Okay, infectious causes.
Infectious causes can be tuberculosis.
That's a good thinking, yes.
Then retroviral infections.
Retroviral infections, excellent thinking. Good.
Then urinary infections.
Urinary infection without dysuria going for 6 months, of course possible.
Abscess formations.
Abscess, which abscess can last for months together like this, 6 months? Abscesses missed anywhere can present like this. Common abscess which keep on missing is subdiaphragmatic abscesses.
Okay,
injection abscesses, gluteal region, sometimes we miss it unless you specifically look for it. And you said malaria. Malaria, 6 months fever, possible. Chronic malaria, possible, yes.
Infective endocarditis.
Endocarditis can go like this, yes, good.
Bone and joint infections.
Septic arthritis, you mean?
Yes,
septic arthritis is commonly an acute problem.
Okay, sir.
We'll go to the next complaint, fatigue. What's your differential diagnosis? The fatigue and fever together. Can you get fatigue in the endocarditis? Yes.
Yes, sir.
All infections, you can have fatigue. Retrovirus infection, you can have fatigue. Can you have fatigue with the myelostenosis? Yes. With the fever, endocarditis? Yes. So anything is possible with fatigue. Weight loss.
Weight loss can also be due to some malignancies.
Malignancies, yes.
Due to renal failure.
Weight loss, renal failure means acute or chronic?
Chronic renal failure.
What are the common presentations of chronic kidney disease?
Urea.
Pardon?
Edema.
Chronic kidney disease usually presents with renal complaints, namely polyuria and nocturia. When there is polyuria, you don't get edema. So one system affected in chronic kidney disease is GI, is the renal system. Second one is you get what's called as gastrointestinal system complaints, namely anorexia, nausea, vomiting, hiccup. This is the second group of complaints for chronic kidney disease. The third group of complaint is in relation to the anemia of chronic disease. They get shortness of breath when they walk, palpitation, fatigability. Fourth group of complaints may be in relation to osteodystrophies, bone pains. And fifth, miscellaneous complaints like pruritus all over the body. Okay, so these are the ways chronic kidney disease present. Chronic kidney disease present as edema only when there is acute or chronic kidney disease. So weight loss goes along with the chronic infections of any nature, malignancies, and systemic diseases of any nature. Myalgia, like staring at you, myalgia. So with this combination, fever, fatigue, weight loss and myalgia, how do you proceed? Name some conditions where myalgia is important complaint.
Systemic vasculitis.
Okay, one systemic vasculitis. Two.
Vaginas granulomatous.
That is vasculitis, no?
Okay. Viral infections.
Viral dengue fever, chikungunya, myalgia, very good. Okay. Yeah, but they are short diseases, not 6 months. Okay, any other? Polymyositis, dermatomyositis can have pain. Polymyalgia rheumatica can have pain. Okay, what is the last complaint? Hemoptysis. How do you look at it?
We can look for respiratory causes.
Like?
Tuberculosis.
Tuberculosis is commonest in our country. What is the next common cause?
Pneumonia.
Pneumonia can rarely produce, yes.
Bronchiectasis.
Bronchiectasis, that's correct thinking. Yes.
Bronchogenic carcinoma.
Carcinoma, correct. What about abscess?
Yes, sir.
Yes. So respiratory causes you mentioned. Say, name some other cause which is common.
Pulmonary hypertension.
Pulmonary hypertension, very cause, very good. What else?
Pulmonary edema.
So pulmonary edema, you get pink frothy sputum. Yes. And mitral stenosis is one important cause for pulmonary hypertension. Hemoptysis. Okay. Any other
Good-Pasture syndrome.
Good-Pasture. So renal disease. Very good. Good-Pasture syndrome. So renal, you said respiratory, you said cardiovascular. Now you said renal system. Yes. Any other?
Then vaginas granulomatous can present.
Also connective tissue diseases. Connective tissue diseases can present as, okay, so you said TB, you said carcinoma, bronchiectasis, pneumonia, lung abscess, then you said cardiovascular causes, then you said renal cause, you are saying connective tissue diseases. So out of this, which one you prefer? So you use so many different diagnoses you are given, starting with HIV, which one is fitting with your thinking here? Do you consider pulmonary embolism in this patient? Can pulmonary embolism produce hemoptysis?
Acute symptoms.
When does it produce hemoptysis? Yes, pulmonary embolism can produce hemoptysis, but there may be an underlying cause for pulmonary embolism which may be producing fever. Okay.
Okay, sir.
Okay. Are there any other conditions where you can have cavities and bleed other than connective tissue disease and tuberculosis?
Coagulation disorders.
Especially drug abusers who usually inject drug through veins. They may get staphylococcal endocarditis of the right side walls, tricuspid valve, and the vegetations get detached. It goes to the pulmonary system, lungs, where it produces areas of pneumonia, breaking down cavities, and you can have hemoptysis. Another condition which you must remember, although very rare, is what is called as melioidosis, where you find abscess anywhere in the body, skin, subcutaneous tissue, liver, lungs, everywhere. That can also have this type of presentations. Okay, so your differentials are
tuberculosis,
good.
bronchogenic carcinoma.
Each one will say the points against. Myalgia does not go with tuberculosis. Rest of it is okay. Second possibility is bronchogenic carcinoma. Again, myalgia does not fit with it. Okay, next one.
Lung abscess.
Lung abscess. Okay. When you say about suppurative lung diseases, you have three entities. One is lung abscess, second one is bronchiectasis, third one is empyema. By and large, bronchiectasis is a chronic disease and lung abscess is an acute suppurative gangrene of the lung where patient will die after few months. Cannot survive 6 months with lung abscess. Empyema, of course, chronic empyema may be there. Okay. Next possibility. What is the point against being HIV infection? It goes with it, except even myalgia, everything can be explained. HIV infection is a strong contender. You said something now?
No, sir.
You said some malaria. What did you say? No. Any other differential do you have? Goodpasture syndrome, 6 months is unusual. It's an acute disease process. Okay, they have cough and hematuria, renal involvement, hemoptysis, but weight loss, myalgia may not be the picture, and 6 months also may not be the picture. Yes.
Vasculitis.
Any problem with the SLE in this patient? Can you have all this with SLE?
Yeah,
except for the baby. But what? Tell your point.
First of all, it is a male patient. It is
Males,
predominantly females.
That's true. Very good. Okay.
Then malar rash is very common.
No. It is a malar rash is not very common in our color. In Caucasians, maybe it is very prominent, but we may not have. And even in Caucasians, it is not 100%. Not compulsory to have malar rash.
Hemoptysis is.
Yes. One of the complications of SLE is pulmonary hemorrhage. They can have pulmonary hemorrhage. Okay. If it is associated with APLA, they can have pulmonary embolism. Again, hemorrhage. They can have bronchoalveolar bleed. Apoplexy, very common with SLE. Any other possibility? So you put forward very good possibilities. You said infections, you said malignancy, you said pulmonary embolism, pulmonary hypertension, bronchiectasis, and you said connective tissue disease. Excellent discussion. Very good. Okay. So what history you want to differentiate among them? We already got the differentials with you. Yes. Go back to the infections. What all history you want in this case? Extra.
For infections, we are thinking about tuberculosis. So we
Contact
have
history.
Contact history.
That's okay. Malignancy. Weight loss producing malignancies as we thought of. What are they?
Sorry, sir.
Weight lossing malignancies. There are certain malignancies which weight loss is very common. Stomach, colon.
Colon carcinoma.
Oh, that's right. So they present as weight loss. Pancreas, weight loss. So symptoms pertain to that. Pulmonary embolism.
Pulmonary.
Predisposing factors. Thrombophilias.
Breathlessness.
Appler syndromes. SLE. Bedridden patient. Patient with a fracture. And acute onset for acute pulmonary embolism and chronic thromboembolism is also there, which can present as pulmonary hypertension. Come to pulmonary hypertension, suggest a history. If it is secondary pulmonary hypertension, there may be history of predisposing illness, maybe cardiac, maybe respiratory. But if it's a primary pulmonary hypertension, maybe they have only chest pain, shortness of breath. Bronchiectasis, conventionally history will be chronic. First complaint will be cough with expectoration. That's not the case here. Okay, the word cough is not mentioned and expectoration is not there. No post variation. Connective tissue disease, what all things you want in the history. Which connective tissue disease in your mind? And for that we have to ask the history now. Now narrow down the connective tissue diseases we are thinking about.
Goodpasture syndrome.
Goodpasture syndrome is 6 months. What symptom you want to ask? Goodpasture syndrome. So usually it's a male patient who is a smoker. Smokers have more chance to get Goodpasture syndrome, and they have associated acute renal shutdown, acute kidney injury like picture, oliguria, hematuria, and they rapidly go down, producing acute renal shutdown. Okay, next condition.
Vaginous granulomatosis.
What history you want for vaginers? There's a new vaginous older term.
Upper respiratory tract infections.
What do you mean by upper respiratory tract? What's upper respiratory tract?
Till like sinusitis.
No, where are you from? Chart and where does it end? Upper respiratory tract.
Till C6 level.
It is up to vocal cords. So, what are the manifestations in the upper respiratory tract for vaginers?
Rhinitis. Sinusitis.
Rhinitis. Very good. Sinusitis. Epistaxis. You have got otitis. Okay. You get stridor, subglottic involvement. Yes. Any other than upper respiratory tract? What else?
Any history of eye involvement?
Eye involvement, maybe episcleritis, redness. Scleritis, redness with diminished vision. Uveitis, diminished vision with watering and redness of the eye. So a minimal amount of conjunctival erosion may be there. Again, redness, the severe pain. They can have retroorbital tumors, producing pseudotumor, producing proptosis. That's also possible. Skin, what skin lesion you want to know?
Any palpable purpura?
He had palpable purpura. What else you want to know? Ulcers,
Any vesicle or necrotic ulcers?
That's right. Bullous lesion, vesicular lesion. What else you want to know? Renal involvement in the form of hematuria, oliguria, frothy urine, reason hypertension. Anything else in the history? You want about arthritis. So that it must be asked for. And then you have an involvement of nervous system in the form of peripheral nerve involvement. Peripheral nerve involvement. This is what you ask for vaginals. What else is the connective tissue disease you're thinking about?
Polyangiitis nodosa.
It doesn't produce hemoptysis. It can produce fever. It can produce fatigue, weight loss, myalgia. Hemoptysis doesn't speak for it, and age and sex is commonly seen in male patients, usually around 40s, 50s. So that's also possible. Any other?
Microscopic polyangiitis.
Microscopic polyangiitis is a close mimicker of vaginal granulomatosis. It can have renal involvement. It can have pulmonary involvement. It can have fever, fatigue, weight loss, everything. Anything else? What about SLE? What do you want to ask? Hair loss, alopecia, oral ulcers, palatal ulcers, different types of skin lesions, urticarias, vasculitis, purpuras, arthritis, anything else? Renal involvement, hypertension, pneumonias. So these are your basic questions you ask for finding out the differential diagnosis. So history has to be more elaborate in this patient. This particular patient had chronic headache for 10 years. He had epistaxis 4 years back, and he underwent surgery for left ear. Now he has got paresthesias of the left lower limb, paresthesia only of the lower limb, and weakness of the right lower limb. And now his treatment for hypertension is going on. That's of recent onset. After hearing this history, what do you think?
There is history of upper respiratory tract infections.
Yes.
Then he has chronic headache.
That may be part of the sinus infection.
Sinusitis.
Okay.
Then history of surgery for left ear.
That may be mastoid infection or otitis. Okay.
Then CNS involvement.
Central nervous system or peripheral nervous system?
Peripheral nervous system.
So there is evidence of lower motor neuron lesion, paresthesia, left lower limb, weakness right lower limb, and hypertension recent. So, okay, so the clues. So history continues, fever, infection, inflammation. So we mentioned that we can pulmonary embolism. So risk factors for DVT. So what is Wells criteria?
I don't know, sir.
Okay, we will come to that later on, the JR. So this much things we have to ask. Weight loss, malignancy, infection, inflammation, recurrent lung infection. Why do people get a recurrent lung infections? Why don't a normal person do not get recurrent chest infections?
The ciliary function.
So one is your ciliary function. Which are situations where cilia is not there?
Carcinogenesis syndrome.
And commonly, cilia is absent in smokers. So they get chest infection. Those who are working in a very dusty environments, they may not have the cilia. And when you have upper respiratory tract infection, your epithelium may be desquamated for time being. At that time, you get secondary infection. So you have got mechanical barriers, this may be lost. Then you have got non-mechanical barriers against infection. What are they? You have got immunity, innate immunity in the form of
humoral immunity.
Humoral and
cell-mediated.
Cell-mediated immunity. Can you give an example of cell-mediated immunity problem? Retrovirus infection. Retrovirus infection. Here you got a humoral immunity problem. Give an example. Congenital hypogammaglobulinemia, common variant immune deficiencies, acquired condition like nephrotic syndrome. Okay. Now, what are the features of small vessel vasculitis? How will you suspect? Last time we discussed about the large vessel vasculitis. We said claudication is important problem. Presentation. Small vessel vasculitis, how do they present?
They can affect the lungs and kidney.
It can affect the skin in the form of purpura, petechiae, vesicle and bulla. It affects the kidney, producing glomerulonephritis. In the lung, it produces bronchoalveolar hemorrhage, formation of cavity or pneumonia. Mononeuritis multiply or mononeuritis is another manifestation. It can affect the gastrointestinal system and it can affect the eye. So before that, what is the definition of small vessel vasculitis? Small vessel, what is it?
It includes the arterioles, capillaries, and the small veins.
These things which you cannot see with your naked eye. They are the ones, okay? So, what are the examinations specific for small vessel vasculitis? So, everything is given here. You examine the eye for fundus, look for GIT examination, specifically look for peripheral nerve involvement. You look in the lungs, kidneys, purpuras, and this patient had pitting edema. His blood pressure was 200 by 110 and he had saddle nose, palpable purpura, right foot drop, left lateral foot paresthesia, left side of the foot, left lateral foot. Which nerve supplies that area? Common peroneal nerve. And right foot drop is produced by what? Right common peroneal nerve. Right wrist drop is produced by what? Right radial nerve. Left ear was deaf. What's the reason? Possible reason? You already mentioned there's an involvement of the upper respiratory tract, including the ear, otitis media, externa, interna, anything can be there, producing deafness. And he had pulmonary involvement, bilateral crackles. So he was hypertensive, he had edema, and he had saddle nose. What do you make out of that? When you say saddle nose, first thing comes to your mind is this leprosy.
Okay.
Second common thing is saddle nose is syphilis, congenital syphilis. The third thing we look for is vasculitis like Wegener, where vessels are occluded and upper respiratory tract midline is diseased, and you may get into trouble.
Okay.
People who use cocaine abuse, they may also get involvement of midline structures like nose. That is possible. Okay. So what are the examples of small vessel vasculitis?
Vaginous granulomatous.
What's the new term for vaginous? Go ahead. Vaginous, yes, next one.
Microscopic polyangiitis.
Good.
Then Goodpasture syndrome.
Is it a vasculitis? It's an anti-glomerular basement membrane antibody mediated disease.
Shug-Strauss syndrome.
You already discussed last time. Eosinophilic, no? Yes. What else?
Behçet syndrome.
So we have Granulomatosis polyangiitis. That's a new term for Wegener. And eosinophilia with eosinophilic granulomatous polyangiitis is the previous Thurstow syndrome. Microscopic polyangiitis already mentioned. Henoch-Schönlein purpura and cryoglobulinemia. How will you recognize Henoch-Schönlein purpura? Other complaints.
Palpable purpura.
They usually come with abdominal pain. They got complaint. Second complaint, arthritis. Third complaint, they got abdominal pain. Okay, so purpura, abdominal pain, arthritis. There may be hematuria or renal involvement. So cryoglobulinemia is another one. producing small vessel vasculitis. Clinical features specific for small vessel vasculitis. Tell me. Okay, so we have already said upper respiratory tract involvement, lower respiratory tract involvement, eosinophilic dilated polyangiitis and bronchial asthma, eosinophilia, and allergic rhinitis. Microscopic polyangiitis does not have specific things, non-specific thing, and HSP has got specific features. And livedo reticularis, palpebral purpura, Mondex multiply is pointed towards cryoglobulinemia. What is livedo reticularis?
They have purplish lesions.
How do they look like? Just like a net. Just like a net. Okay. Listen. What investigations you plan in this case?
Common complete blood count.
Complete blood count.
ESR.
Okay.
And we can do an
just think back what all signs he had, what all symptoms he had. For that you have to investigate. He had ESR 110, he had hemoptysis. So what investigation you want?
CRP.
CRP is a good investigation. What is the first investigation you do when somebody comes with hemoptysis?
Chest X-ray.
Chest X-ray. So in this particular patient, chest X-ray showed cavity. So what will be a differential diagnosis for cavity in the lung?
Tuberculosis.
So infections. Common STs, tuberculosis. Other infection. Lung abscess comes as cavity. Then you have got septic emboli. As you already told, somebody with a drug addict, right side, embolus is coming. So infections can produce rapidly breakdown cavities are seen in Klebsiella pneumonia. We have abscesses in case of staphylococcal pneumonia, suppurative pneumonias. Second group of condition is malignancy producing lung abscess, which malignancy commonly break down. Squamous cell carcinoma, and is usually seen in the near to the midline. Is a thick-walled, irregular-walled cavities. The third group of condition producing cavity in the lung is the rheumatological problems like Wegener's granulomatosis. Can rheumatoid arthritis produce cavity in the lung? Yes or no? Rheumatoid arthritis can produce nodules inside the lungs, and it's not usually in the upper lobe, and it can break down. So it becomes an important differential diagnosis for other cavities. So you have seen the cavity, you send the sputum for AFP, which is negative. You had done the urine examination, shows RBC plenty and few WBCs and casts also. Urea is high, creatinine is high. What else you want?
And the neutrophil
cytoplasmic antibodies, ANCAs. So you want to do ANCA. We did all the ANCAs, C ANCA, P ANCA, and here C ANCA has come as positive. C ANCA is PR3 ANCA. PR3 ANCA is positive, 3+. Creatinine is high, numerous RBs and cast, X-ray shows cavities, and CT scan shows chronic rhinosinusitis. So where are you now?
It could be probably vaginous granulomatosis.
Possible vaginous granulomatosis. There are the criteria, but basically what we must remember is upper respiratory involvement, lower respiratory involvement, renal involvement, peripheral nerves, in this cavity formation in the lungs, with the background of ANCA positivity, should give you high index of suspicion for this diagnosis. There's a good diagnosis, and how do you treat this patient?
corticosteroids and immunosuppressants.
So with this particular patient, he had heavy dose of corticosteroids. If I remember correctly, he had 3 doses of methylprednisolone, followed by 1 mg per kg of anti-inflammatory dose. Prednisolone was given, and we gave him intravenous cyclophosphamide monthly for 6 months, and then in between he was on steroid tapering doses. At the end, we put him on small dose of steroids with the methotrexate, and he improved very well. Creatinine is just above normal, otherwise everything has reverted back normal. With antihypertensive medications, he has improved. The little bit of physiotherapy, his power of the muscles has come back, sensory stimulants has disappeared, minimum amount of food drop is still present. Otherwise, he is doing extremely well. So, there are 2 phases for treatment. You had to decide whether it's an organ or life-threatening disease, in which case you had to give pulse steroids. This patient had hemoptysis, he had a saddle nose, he had a mononeuritis multiple. He was given high dose of steroids after pulsing the patient for 3 days. 1 gram was given methylprednisolone for 3 days, that's pulse, then high dose steroids, tapered, and then we gave cyclophosphamide also. Patient was maintained on methotrexate in this case. Other options are there, mycophenolate, azathioprine. But whenever we give these patients on this type of drugs, we must take care of prophylaxis against pneumocystis also. Pneumocystis also comes as an important problem.
Okay.
So going back to the case again, this patient presented with chronic ENT problems to the general practitioner. So if you are general practitioner, somebody comes with sinusitis, when will you suspect against granulomatosis?
If he has
if it is chronic,
pulmonary,
he is not responding to treatment. 2, 3, if you have systemic manifestations. 4, if he has got special organ affection like eye, nerve, purpura, then you must think this is the problem. Okay, this patient subsequently developed hoarseness voice. How to explain that? That's because of subglottic stenosis. This affects the whole of the respiratory system. So subglottic stenosis produces hoarseness and sometimes even stridor. And his friends were telling him that one of his eyes was a bit bulging forward. How to explain that? Pseudotumor of the orbit was the reason for that. If this patient develops red eye, what are the possibilities?
conjunctivitis,
One possibility is conjunctivitis.
scleritis,
How to differentiate scleritis from episcleritis? Basic ophthalmology. Episcleritis is redness of the eyes, very superficial, does not have any complaints, doesn't have much sequelae. Scleritis, on the other hand, is a very painful disease. If you leave it alone, it goes and affects the structures inside. Up to the retina it goes, and it can produce problem of your vision. So scleritis is painful and it can affect your vision. Prognosis is bad compared to episcleritis. Why did this patient develop hemoptysis? What are the possibilities you consider there? You already said there's a cavity. No, you said there's cavity
cavity.
and there's a chance of pulmonary embolism in this case. And also we said he's a candidate for bronchoalveolar hemorrhages. If you want to get a proper diagnosis, ideally we must have a biopsy. Biopsy can be from anywhere from the respiratory system, nose, or any tissue which is available for you, or even renal system. An important point is it's a pauciimmune type of glomerulonephritis with a crescent formation. So you can see evidence of chronic inflammation. You can see evidence of non-caseating granuloma. You may see evidence of vasculitis, and you may get what's called a geographic type of necrosis. And X-ray classically produces cavity. What else can be there in the X-ray? It can come as an infiltration, so may think it's tuberculosis. It can come as a mass, so may think it's a carcinoma. It may come as cavity. Again, we have problem. Nodule, you may think it's metastasis. Patient is not doing appropriately well. Okay. So, a couple of questions for JR. Yes. What are the antigens in ANCA? What are the antigens in ANCA?
P-ANCA and C-ANCA.
Yes. What are the associations of P-ANCA?
P-ANCA is associated with granulomatosis with polyangiitis. All the other ANCA have associated vasculitis like microscopic polyangiitis.
And ANCA C is associated with? ANCA C associated with Vaginous granulomatosis. ANCA P is associated with microscopic polyangiitis. Now tell me some causes for RPGN. What is the full form of RPGN?
Rapidly progressive glomerulonephritis.
When do you say the glomerulonephritis is rapidly progressing?
Less than 2 weeks, worsening of serum creatinine and renal function within less than 2 weeks. Patient going into anuria and the complications of renal failure like metabolic acidosis and hypokalemia, requiring renal replacement therapy.
Now, if you do biopsy, what are you expected to see?
Crescents.
How many number of glomerulus must show crescents?
More than at 50%.
Yes, within how many months? Within how many months? Within 3 months.
Within 3 months.
Okay. So, what are the other conditions producing RPGN?
Cast nephropathies, rhabdomyolysis,
anti-glomerular basement membrane disease. That is Vasculitis syndrome. Okay. So, immune complex mediated glomerulonephritis, as in case of SLE. And vasculitis condition. Third one is vasculitis, just like Wegener. And fourth one will be idiopathic. Okay. So the question about this scleritis is already mentioned. So tell me the side effects of mycophenolate, mofetil.
General side effects like constipation is a common side effect. Then nausea, vomiting, headache is also predominantly seen. Fluid retention, edema.
Edema, very good. Edema is important one. Yes, okay.
Hematuria can be seen.
Hematuria can be seen. They are
then associated fungal infections like candidiasis, thrush.
Anemia. What happens to blood pressure?
High blood pressure with there can be hypertension.
It may be secondary hypertension. So that's another side effect. And if you just look at their count, what will happen? And some of them are anemic. If you look at the count, what all things can happen?
There will be high level. There can be high levels and low levels of red blood cells. Both can be there.
Say correct term for that.
Leukocytosis and leukocytopenia both can be there.
Yeah, both can be there. Okay. Now tell something about bronchoalveolar hemorrhage.
Bronchoalveolar hemorrhage is.
What are symptoms?
Patient presents with tachypnea, orthopnea, tachypnea in the setting of an infection, seen with infections like hemoptysis. Massive hemoptysis can be there. Setting of infections like leptospirosis, SLE. Usually
SLE is not infection. SLE is not infection.
With inflammatory conditions like SLE, also pulmonary alveolar hemorrhage is seen commonly. There will be hemoptysis is the main presenting complaint.
Hemoptysis main complaint. So what is the difference between bronchoalveolar hemorrhage and pulmonary renal syndrome?
In pulmonary renal syndrome, due to basement immune complex mediated activity in the basement membrane, patient has hemoptysis, but this is a more of massive hemoptysis.
No, bronchoalveolar hemorrhage means only hemoptysis. But when you say pulmonary renal syndrome, associated with it, they have got renal failure.
Yes, sir.
Then you call it as pulmonary renal syndrome.
Yes, sir.
Can you name a virus which can mimic like this? Can you tell something about hantavirus? Hantavirus.
Yes, sir. There can be pulmonary alveolar hemorrhage with hantavirus infection.
It is a mimicker for leptospira
Leptospira.
hemoptysis.
Yes, sir.
Okay. So tell me something about treatment for bronchoalveolar hemorrhage. Suppose it's the case of Wegener, what will you do?
Steroids, the glucocorticosteroids, prednisone pulse is indicated if there is pulmonary alveolar hemorrhage.
Do you have any other option?
Plasmapheresis is also indicated if the patient has.
No. You commonly give for rituximab or cyclophosphamide.
Yes, sir.
Suppose it's a Goodpasture syndrome, what's the treatment? Plasma exchange and cyclophosphamide is the treatment. Suppose it's SLE, what's the treatment?
Rituximab in pulmonary alveolar. If there is pulmonary alveolar hemorrhage and SLE, rituximab.
And if it's APLA, what's your treatment?
Steroids and
Rituximab.
Rituximab steroids.
That has to be given. So last part of the problem is we are discussing a case of vasculitis here. What are the mimics of vasculitis? Mimics.
Infectious causes like endocarditis.
The mimicker means clinically they mimic, biochemically they mimic, radiologically they mimic, histopathologically they mimic. That's what we mean mimickers.
APLA.
Apply
then TTP can mimic vasculitis.
Full form?
Thrombotic thrombocytopenic purpura.
Very good. What else?
Then anti-GBM disease like Goodpasture syndrome.
Name some infection.
Gonococcal infection if it becomes disseminated. Syphilis.
Very, very rare. Common things.
Endocarditis.
Endocarditis and HIV are two important mimickers. Can you name some recreational drug which can produce a mimicker?
Cocaine.
Okay.
Cocaine, amphetamines.
Name some neoplasia which can mimic. Myxoma. Lymphoma. Myxoma produces fever. What are the symptoms of symptoms of myxoma? Can you tell something about myxoma?
Patient examination findings, there will be murmur with
history.
Systemic
PO.
symptoms. PO.
Arthralgia.
Yes, sir.
Hemiplegia. Embolism. Okay.
Yes, sir.
And then of course the murmur, then dyspnea and so on. Okay.
Yes, sir.
Sometimes cholesterol embolism can also mimic this pattern. Okay.
Yes, sir.
These are the common things coming as mimickers. There are so many mimickers, you should never ever miss them. Okay.
Yes, sir.
Why, how do you differentiate this Wegener from rheumatoid arthritis?
In Wegener's, there will be associated other system involvement, like as we said, pulmonary involvement, upper respiratory tract involvement, which will be more predominant, and there will be fever, which is not seen with which is not commonly seen with rheumatoid arthritis, and the renal involvement.
Rheumatoid arthritis is classically a disease of small joints.
Yes,
large can also be affected. Here it's just reverse, it is large joints. Extraarticular, of course, not commonly seen in rheumatoid arthritis. How to differentiate this condition from microscopic polyangiitis?
in microscopic polyangiitis, upper respiratory tract involvement will be less because more it is seen with vaginous, and the renal involvement will be predominantly seen with vaginous granulomatosis.
Okay. So last question: can IgG4 present like this?
Yes, sir. It also presents with PUO with this similar systemic complaints.
Does it produce this type of pulmonary manifestations? Cavitation? No. Does it produce this type of renal manifestations? No. So these are basic differences. What are structures affected in cocaine? Cocaine abusers. Usually the midline structures are affected, like nose and the palate. That's how it comes in the differential diagnosis. So the most important point in this case is the involvement of upper respiratory tract with the lower respiratory tract, chronicity and systemic manifestations. Okay.